just go.
Hey, I'm just trying to get this to share my screen so I can get it up for you. Hold on one sec.
Got it. It's still not quite 5:30 yet, so we'll wait a minute or two. We have an extra special guest that I'm going to introduce in a couple minutes before we start, Anthony. There he is in his car. Matt, how are you?
Apologies for the auto background. This is actually just my background of my desktop. It's not
Is
really.
that what it is? It's really nice. You got a nice sunroof, a nice like tree in the back.
Thank you. Really appreciate you guys having me. Thanks.
No, we'll look forward to it. Hopefully we can do this more. I'll give you a quick, I'll just introduce you to the group real quick, Matt, and then let you listen in. If you got to drive, don't worry about it. But
nope, I'm stationary. I'm good. Thank you.
Okay. Dan, are they out of the OR? Do you know? Is Divvy in the OR or?
Dr. Divvy's still going with Colin.
Yes.
Yeah. I'm going to shoot you a text with some images. DJ just got his MRI done.
Okay.
He just got out of the scanner. So I'll send you those real quick.
Okay. We'll come up with a plan. Maybe we have to do something tomorrow. We can figure that out. This is being recorded, so let's not do any patient stuff while we're recording it. Tony, are you good, you think, or do you need another minute or two? I'll take that as a still working on the image on the screen share. Hey Dan, you don't have to send me all the pictures. After we're done, I'll look through them online and give you a plan.
Perfect. That'll be a lot easier. Thanks.
Yeah. Everybody having a good Cinco de Mayo? If we were in person, we would do tequila shots and, you know. All right. I'm going to text Anthony real quick and see what's going on, if he's good.
Hey, I'm sorry. Still trying to get it to load here on my computer. It's not allowing me access on my laptop for some reason to share the screen. So I'm trying to send it to myself to load up onto.
Otherwise, you know what, Anthony, send it to me. If
Uh-huh.
if it's one of those Northwestern host issues, if you send it to me, I can load it up and I can move the slides for you.
Or I just sent it over to Northwestern Computer.
Okay.
So I'm going to try to load it up there and just get it started from there.
Okay. If not, just go ahead and just forward it to me. Okay.
Will do.
So guys, thanks for logging in. We're just working through a little technical issue to get Anthony's talk on screen share. I hope this time's working better for everyone. 5:30 seems a little bit more feasible, although still some folks are in the OR. We get that, but I think we'll stick with this time for now. We've got a couple more talks to go before we get through the curriculum for the year. But I think we've covered some really good topics so far. We've got a couple of the talks coming up from the fellows. Anthony's our neurosurgery fellow who's with us this year, came to us from Georgetown, and then is off to, Anthony, remind me where?
I am off to Hackensack Meridian Health in New Jersey.
Yep, to New Jersey. So he's going to be fixing all the bad stuff that the New Jersey spine surgeons do every day. So he'll revise all that and make those patients' lives better. So hopefully we can get that screen share up and going. Otherwise, send it to me, Anthony. I do want to just mention real quick, we have Matt Coleman from Rush joining us. Dr. Coleman's on the faculty at Rush with the Rush Ortho Group. And he and I were talking last weekend about the content that we sort of created individually for our fellows and our residents, and how it's relatively easy to share it, given the fact that we're doing these online for now. And so if we can put on a good show tonight, maybe we'll get Dr. Coleman to come back again, or maybe get some of his fellows to join us as well, and see where that takes us.
Dr. Patel, thanks for having me. I love the collaboration and love it seems like it gets harder and harder to sit down and really talk about cases in depth and spend time on the teaching. So sure. I appreciate the chance to join you guys. Love that you guys do this. Hopefully we can, like you said, do it more often.
Absolutely. Yeah. It got us through COVID for a big chunk of last summer.
Yep.
We were on radio silence. And so we did this, and it was a chance for everyone to see each other, even if it was and we were doing it 3 times a week. I don't know if you guys remember that, but we did it Monday, Wednesday, Friday for a couple months. And it was like our only chance for human contact. That's outside of my kids, but that just kind of counts.
Nice.
All right, Anthony, what do you want to do, bud?
I sent it over to you.
Okay.
If you want to load it up.
Yep. Give me 2 shakes to download it, and I will pull it up.
Yep. Sorry about that again.
No worries. All right, so Anthony, I'm going to go ahead and screen share it.
Okay.
And then I'll try to match your talk, but if I'm not moving along, you can go and sort of say next slide, or you can go back a slide and I'll run the slides for you.
Okay, sounds good.
All right, bud. Thanks again, Anthony, for putting this together.
Yeah, and sorry, everybody. Thank you for bearing with me over here. Apologize for the technical difficulties. I'm Anthony Conti. I'm the spine fellow on the neurosurgery side over here. Yeah, today my talk is on common complications in lumbar spine surgery. So we'll get started. So what are we going to talk about today? As I just mentioned, we're going to talk mostly about complications that we commonly see in adult degenerative lumbar spine surgery. How we're going to discuss about techniques on how to avoid these complications when these complications do happen, what are kind of effective treatment options to help resolve them, and also just taking a look at the individual specific complication profiles of some different surgical techniques involved in degenerative lumbar spine surgery. What I didn't want to talk about, I didn't want to get too much into the tumor and trauma and thoracolumbar deformity. A lot of those complications will really overlap with a lot of my talk today, but there are some just specific complications in each one of these little subsections of spine surgery that I really won't get into too much detail with today. So why talk about this subject? Well, first of all, everyone gets them. Every spine surgeon has complications. I know going into or about to go into my own practice, my big fear now is that I have my own patients to have my own complications with. And the biggest thing that I need to do is be prepared to talk openly and honestly about them with my patients. So, that's one of the biggest reasons to have this talk. We know that complications beget more complications. And if we don't know about them or not prepared for them, we'll just keep repeating them. And then just, some complications have been tried and true throughout decades of spine surgery. Some we're just knowing. So it's good to just freshen up on the literature and freshen up on, different new findings on what techniques or what different things are going on in the spine world that can cause complications. And then most importantly, we're talking about this, and you can go to the next slide, because in complications for lumbar spine surgery, they just lead to, increase in healthcare costs. They lead to our patients having higher reoperation rates. And most importantly, they just lead to worse short and long-term complications for our patients, which is the most important thing. So who gets these complications? Well, the elderly get these complications. They are one of the most at risk for complications, both medical and surgical, following degenerative lumbar spine surgery. And as you go forward, you see that there's different subsections. There's the under 60 crowd, there's the 60 to 80, and there's the over 80 crowd. And really, it's in the over 80 crowd that you really start seeing a jump up in increase in medical complications, increase in patients that are admitted to acute rehab for even just smaller degenerative lumbar surgeries, and patients that have higher 30-day admissions rates following lumbar spine surgery. And these medical complications are across the board. You see higher rates of UTIs, pneumonias, postoperative congestive heart failure. So it's really important to not just identify what complications exist, but who are the subsections of patients that are really at risk for these types of complications. And with elderly patients, the surgical factors that put them most at risk is higher number of operative levels and increasing complexity of your surgical cases, definitely. But also longer operative times, higher EBLs, making it even more important to try to get the patient off of the table as quickly as possible. So that makes it really important to, especially for this crowd, to really employ clinical judgment in how much is too much for a patient over 80, really being precise with your surgical selection and really working to medically optimize them preoperatively, whether that be pre-op medical clinic. And even studies have shown that using a geriatrician or a medical or internist following the surgery has drastically decreased medical complication rates in this over 80 group. Another subsection is obese patients. And, what we find is that a host of complications associated with a BMI greater than 30. You have definitely increased rates of surgical site infections with increasing depth of subcutaneous tissue that you see. You have across the board, similar to the elderly, increasing rates of medical complications with these patients, DVTs, PE, sepsis. You have longer operative times because the increased body mass makes these cases more challenging, and then also worse short and long-term outcomes that you see as well too. It's unclear. I've seen conflicting reports in the literature about whether it puts you more at risk due to increasing complexity in some of these cases for dural tears and neurologic injury. I think with also the advent and increasing popular and minimally invasive surgery, this is cut down on some of this, especially in the infection rate as well too. But it's definitely a subsection of people that you need to be aware of, and you need to counsel preoperatively about weight loss management and medical comorbidity management to decrease your complication rate. So I'm going to jump right into different types of complications we see in lumbar spine surgery, starting with durotomy. Now, durotomy, there was one systematic review going over 10 years that I've read of a quoted unintentional durotomy rate of around 8.1%. Now, differing reports vary just on how much that rate really is. I've seen roughly generally around 4 to 5% for kind of these virgin cases, which definitely increases even to levels that I've seen at above 10 to 15% for patients with reoperative patients, and definitely the different types of pathology as well too, they will differ with. Studies have shown that durotomy rates definitely increase with patients with degenerative spondylolisthesis and kind of these kissing facets that make your surgical approach that much more difficult. And definitely in the elderly population of even above 60, you start to see an increased incidence of durotomy in these older patients. So I even read elsewhere, and I know some of this can be controversial, about lumbar epidural spinal injections increasing your durotomy rate as well too. What I've seen in the literature is that more acute lumbar epidural injections, usually less than 6 months, has been shown to put you at a more increased risk for durotomies. But after that, the trends to kind of even out after that in terms of people that haven't received them. So why is durotomy important? For several reasons. Durotomy in the case, you could suction up nerve roots, you can directly injure a nerve that could lead to sensory changes, postoperative weakness. Delayed event could be if the durotomy is not healed, not identified, you can get nerve root entrapment postoperatively that can lead to pretty excruciating postoperative pain in these patients. And then you start to see different types of complications that could really hinder you down the road if a durotomy is not dealt with kind of right then and there. You can get postoperative scarring, arachnoiditis of the nerve roots. You can get meningitis. You can get these low pressure headaches from CSF drainage. But more rare, I've heard case reports of kind of remote intracranial hemorrhage, cerebellar hemorrhage. I think I've seen in my training one operative subdural hemorrhage from CSF leak, but there have been varied case reports of that. Even discussion about whether this does increase your pseudoarthrosis rate or your surgical site infection rate just from local destruction of the muscle and soft tissue from pseudomeningocele formation. But I think that really some of the most common lasting effects or lasting complications we see from durotomy are pseudomeningoceles and CSF fistulas that can put us at increased risk for infection and meningitis. So that picture to the right that you see is this large pseudomeningocele that spans from L2 to S1, and really this persistent leakage of CSF that constitutes pseudomeningocele formation could be a real kind of nightmare for patients going down the road. If you go over to the next slide, sorry. So what is the data behind kind of what we do to prevent this from happening, and what do we do if and when this does happen? So first off, in the case a durotomy should try to be repaired at all costs, there's been discussion whether we should try to use kind of sutures that have a suture to needle ratio 1:1, because even if you repair it properly, there could be some leakage of CSF around the dura that could cause a continuous CSF leak. But generally, from what I've seen in my experience and what I read in the literature, all these following steps seem to assist in prevention of continued CSF leak, whether it be a collagen matrix such as Durgen, fibrin glue or sealant such as Teciel placed over the incision has shown to definitely decrease the postoperative CSF leak rates. Muscle and fat grafts, some people just put a little piece of muscle right over the dural tear. Others that are more in the lateral recess that are hard to identify, you can place a fat graft that lays in that lateral recess that has been shown to reduce postoperative CSF leakage. But I think that most people agree that the most important step in that in closure of these patients is the watertight fascial closure to prevent the formation of a CSF fistula. And then some people elect to do lumbar drains pretty immediately post-op. Some wait to see how the patient does, and we'll place a lumbar drain if it's a continuous problem. Going along the line of drain placement, it was always a big point of contention during my training whether the subfascial drain should be used in these patients with durotomy. And a lot of my attendings would not place a drain in this situation. But from going over the literature, what I've seen is that actually there's little evidence that a subfascial drain will lead to a pseudomeningocele formation or will lead to symptomatic overdrainage to the point of causing a hemorrhage. So actually using a subfascial drain has not been shown to really increase these rates of pseudomeningocele formation. It might be more beneficial to us than it is harmful. Same thing goes along the line of bed rest. Throughout my residency training, it was durotomy, 48 hours bed rest. Let's gradually get them up and see how they do. More recent evidence is showing that early ambulation might be, in fact, just the same as more delayed ambulation greater than 48 hours without some of the medical complications we see of laying flat for 48 hours. So it's kind of a point that I've seen brought up in the literature more and more recently that is food for thought is should we just be getting these patients up immediately after surgery and having them ambulate and see how they do. And then treatment of these, it's tough to say whether just to go right in and try to repair a pseudomeningocele, repair a durotomy. I've seen cases in the literature where that have had pretty good success rates of over 80% with trying percutaneous aspiration of it and a blood patch over the pseudomeningocele to try to prevent future CSF leakage. But really, it's the farther out you go as you get to weeks, months beyond that CSF leak, that success rate really starts to plummet down. So if you were to, the highest success that you would have with that would be soon after surgery. Okay.
Anthony, maybe we'll take a quick pause because we covered a lot already. I like to usually stop about halfway through just to get a discussion going. So on the durotomy side real quick, and Dr. Coleman or anybody else, please jump in. What I generally find is that it's so individualized what each surgeon does to repair a dural tear that the literature gets kind of tough to look at, right? And it gets tough to really assess critically. I've, at least in the orthopedic world, Anthony, there were a couple of large studies that came out of Pittsburgh that really set a lot of the discussions around dural tear management in terms of how much bed rest do we do and how quickly do we ambulate them. But again, all these things you show are definitely options. In my mind, I'm going for as tight of a closure as I can get. And if I can't get a tight closure, then I put something on top, fat, collagen, sealant, and then I keep them in bed longer. The less secure the closure, the longer they're in bed. It's sort of been my gestalt, but I don't have like a set algorithm that I can follow on every single patient. Mm-hmm. I'm wondering, Matt, while we have you, what do you do when you get, that one dural tear a year that you get? What do you do with it?
That's right. I just like my partners, I tuck tail, I call neurosurgery, and I go have a cigarette in the parking lot. Just joking. No, I think all dural tears are kind of different too, So I mean, I think obviously the mantra of primary repair should be followed. I think most people agree with that. If I know that I did the dural tear, like I can see the kerrison bite or I can see the ripcord that kind of tore the dura, then I'm very insistent on, repairing that fresh repair primarily. So I think the principles are get a patty on it, give it some time to rest, go do something else for a little while, because the arachnoid does kind of reconstitute and sort of the leakage will kind of settle down. So I'll just sort of go do something else for a little while. And then I'll come back and I'll be very aggressive with re-exposing that area. So the repairs don't go well when people just don't give themselves room and exposure to do a good repair. So I think those are the principles I follow. But a lot of dural tears, especially in revision surgery, are just atrophied dura. Like there's just this sort of missing gap of dura, especially in the lateral recess. And I find, yeah, Alpesh, it's hard to manage those. You're not going to get a primary repair. I've actually never done a fat graft. I know everyone talks about that. I tend to, if I feel like I have a big defect, I tend to use that sewable Duragen. So not the Duragen that we all just sort of slather on our repair, but there's actually a sewable Duragen patch, and I'll kind of, you don't have to sew it airtight. You just have to get something over it, so you have a hope of some hematoma kind of sealing around it, and just, eventually some healing is kind of the way I look at it. But at the end of the day, for any dural tear, I think the most important thing for me, and I've kind of learned this from watching some of the neurosurgeons. I think neurosurgery tends to look at our institution, look at dural tears a little differently. They do less primary repair. They really have taught me to kind of, it's the best fascial closure I've ever done. So I think as long as you get the fascia closed, a deep pseudomeningocele usually isn't a very big deal. Sure, it could be a nidus for infection and meningitis, but if you can avoid the CSF coming out, the fascial repair, I've had crazy dural defects that are just not repairable, and they go fine. They go fine as long as you don't have CSF coming out the incision. That's been my experience. But this is a whole talk in and of itself, so I'll stop talking. But those are some of the things that
appreciate. That's super helpful to see your insights on it. Again, same thing, watertight fascial closure. A contained what I was taught very much, Anthony, what you said is a contained pseudomeningocele is manageable, right? A meningeal cutaneous fistula is a big problem.
Yeah.
So don't let it become a fistula. I think, in terms of complication avoidance here, that's another conversation, right? Like, can you completely avoid durotomies? I don't think you can. I think in some cases they're a given. One of my favorite quotes was from one of the guys at the Cleveland Clinic. Why am I blanking on his name? Doug Orr. So Doug Orr does a lot of big deformity work, kind of like Dr. Coleman does in some of the cases that we see at Northwestern as well. And he used to quote his patients a 400% durotomy rate, because he told them he's like, I will get 4 dural tears during your surgery. So there's a 400% chance of a dural tear. So I think it's discussing with the patient ahead of time, getting them ready for it, and then just managing it. And I think, Anthony, your point about early ambulation with well-repaired, well-closed durotomies is really a good one, because that older patient population, like you mentioned in the first part of the talk, they don't do well with bed rest. They really don't. They get pulmonary problems, they get urinary retention, they get a lot of problems when you put them flat in bed. So I've been pushing even faster and faster, head of bed movement and then ambulation, thereafter. So the other thing I wanted to ask about, Anthony, I'm wondering what you think about this, because you've seen our protocols about BMI cutoffs and age cutoffs. What do you think? Can we institute a single cutoff and say no one over 80 gets surgery, and no one with a BMI over 30 has surgery? What do you think?
I mean, I think that, I definitely, and that's different from my training, is I've seen a real more strict cutoffs in terms of kind of BMI cutoffs and everything. And, I think that's critical for that. It's, definitely helps with surgical site infection rates. As far as elderly population, I think that with the right preoperative planning, with both surgical and medical planning, I think it can be done in these patients. And I know I was even looking at a paper by, I think, Mike Wang, that had surgical treatment of lumbar stenosis in patients over 85. And he's like, it can be done with a low side effect profile if you select correctly surgically and you preoperatively screen these patients medically and thoroughly. So I think that it definitely, it can definitely be done. I just think it's the right operation for the right person, basically.
Yeah. We've tried to move, Matt, to a really strict BMI cutoff. I think it still varies by surgeon, and we're not 100% on it, but generally over 35, and we tend to tell them to wait. Over 40, and it's a really hard stop, I think, for most of our surgeons. But the age thing, I tried to, a couple of years back, I tried to say nobody over 80 gets surgery. And I didn't, honestly, in the end, I didn't think it was fair to some of those patients. Because in some respects, some of the 80-year-olds are healthier than many of the 60 or 70-year-olds we see. You know, they've lived to 85, 86, 88, 90. They're probably healthier than some of the 60-year-olds that we operate on. So Matt, what do you do?
Yeah, I couldn't agree more. And I actually find the opposite conversation is that octogenarian will come in and say, well, I couldn't ever consider surgery because of my age, right?
Right.
And I talk to them and I say, well, I understand your chronologic age, but how is your cardiopulmonary reserve? How active are you? What are your goals? And I think you're right, Alpesh, that there are 85-year-olds that act like 50-year-olds, and there's 50-year-olds that really should never see an operating room. So individualized care. And as far as BMI, I'm totally guilty of. I actually really, like, to a fault, if I see organic disease that I think is really debilitating a obese patient, I will still operate on them. You know, you pay a price for that. There's definitely higher risks in that patient. So you have to spend the time and really educate them and say, listen, here are the pros and cons. There are significant risks to doing this operation, but I think, you know, without this operation, what chance do you have to really mobilize and be active and to get yourself out of the position you're in? But I think as we see and you know, you probably have a comment on this, Dr. Patel, but as we see the financial risk of complications and the care episode transferred to the provider and away from the hospital itself, I think you're going to see surgeons start to look at that very, very strictly. I'm not personally in that environment now. What do you think about that? How close do you think that time is?
It's there partially because of that pressure about owning the entire episode of care and owning the complication from a contractual standpoint, but more so to what Anthony had talked about in terms of the risks, right? The infection risks in particular.
Yep.
So it's a hard conversation to have, especially in that patient who's having a lot of pain. And what we've basically done is if somebody's myelopathic, if it's cord level pathology and they're losing function, you know, we go, right?
Yeah.
But if it's an elective procedure that can stand to wait, it's a hard conversation to have the first time, but once I've gotten used to having it, I've gotten better and better at sort of delivering it, if you will, to sort of say, it's not that you don't need surgery, you do, you're just not ready for it yet. And if we move ahead, you're going to have a really bad complication. And, you know, it's tough for patients to hear. Some of them probably go elsewhere. Maybe they end up with you. Maybe I'll send them over to you if you want to.
That's right. My secretary's number is 312. Right.
Exactly. But I think honestly, many of them do try. And I'll be honest with you, many of them don't hit the goal of getting substantial weight loss. But if they try, there's something about that individual patient who's willing to try to lose weight versus the patient who sort of says, I can't do that. There's something different about that personality that I think they get better results. So
I think that's a great point.
Our cutoff of 40 is one that I try to stick to. And I've had patients come in with definable operable pathology, and, you know, there are BMIs at 46, 47, and you just tell them there's no way we can do the surgery safely.
Yep. You know, the setting where I'm the most strict with having those conversations is actually bone quality and underdiagnosed and undertreated osteoporosis, but that may be coming later. So, but I'll just say much more so than weight. I'm very careful in that with those patients.
And I treat them the same now. I try to treat bone quality we're hyper vigilant about, but weight also. I just sort of say, I wish sometimes the MRI, when the MRI was up, there would be like a little number that said the BMI while I'm looking at the MRI, because otherwise I get tunnel vision and I'm like, oh, I can fix that.
Right.
You go and meet the patient and you're like, oh, wait a second. There's like 8 inches of fat between me and the pathology I can fix. That's not good. Anyway, but you're well taken. And I think, Anthony, you'll see this, and honestly, for all the residents, you'll see patients that you want to help and you know you can make them better. Mm-hmm. But you've got these modifiable risk factors, and obesity is a modifiable risk factor, and bone quality is a modifiable risk factor. And you can give them the time to get it better. You'll get them through the surgery with a lot better result, a lot fewer complications.
Can I ask, as I go into practice, is there ever a role, or do you ever recommend to patients or refer them over to like a bariatric surgeon in like severe cases where they have like a define obvious pathology, but they're like 40, 45.
I mean, I route it through their primary doctor because
Okay.
I want to manage that. But I do tell them that that's an option.
Yeah.
Especially for folks who are having a fairly substantial amount of back pain, let's say in their otherwise like lumbar spinal stenosis population. If they have a lot of back pain, absolutely.
Yeah.
And I will tell you, there are patients over the years who have come back. The part that amazes me is how often patients will tell me, nobody's bothered to tell me. And they know, like you look at them, they look at themselves in the mirror every day. They know they got a problem.
Yeah.
Their spouse is sitting in the corner, like nodding their head saying, yeah, absolutely, you got to lose the weight. But nobody ever bothers to tell them how important it is. And usually you set goals of like, 10 to 15 pounds. When you've lost like 15 to 20 pounds of weight, why don't you come on back and let's talk again?
Yeah.
And then I usually kick the can down the road another 15 to 20 pounds. And, you get them marginally better along the way. Sometimes their pain gets better. Sometimes it doesn't, Sometimes they keep the weight off more remarkably. And other times post-op, they come back in and they've ballooned back up.
Yeah.
But at least they made the effort. I'll let you keep moving on your talk. We're about halfway done. We'll pause in another about 15, 20 minutes and we'll wrap up.
All right, let me keep moving along then. So I think, this being a talk about common complications, I was actually surprised when I read that the Joint Commission identified wrong level surgery or wrong site surgery as the second most frequently reported sentinel event in the late 90s, early 2000s. And it's definitely a problem that exists in lumbar spine surgery still today. There was one paper that I read surveying, I think, 415 spine surgeons answered, and a large amount of them actually said that they had performed at least one wrong level or wrong operation in their career. And with that entire prevalence, it came out to be almost like 1 in 3,000 surgeries was a wrong level surgery. So, given what JCO saw and a lot of this research, they instituted the Joint Commission Universal Protocol, which just involved what we do every day: pre-op verification, site marking, a timeout before the procedure. But I know, and different institutions have looked at this, that this still doesn't encompass everything that we need for to prevent wrong site surgery. And mostly in our profession in spine surgery, that just means wrong level surgery or wrong level exposure. So I read a paper by Go Coslin and company out in Hopkins, when he was at Hopkins, and they kind of defined their protocol for it as simple as it is. They didn't recommend using a spinous process clamp or a curette underneath the lamina. They thought that can cause some confusion when trying to correlate it with preoperative imaging that you obtain, but rather exposing and trying to place a clamp along that transverse process, which will localize you right to the pedicle of that level. And in doing so, it would offer the most accurate level verification for you. For smaller surgeries like a microdiscectomy, they agreed you can use a spinal needle for localization, but they would highly recommend a second localization shot once you were down to the space of interest as well too, just to recommend. So I know this is something that a lot of us can kind of shrug off and we just continue on, but it is definitely still a common complication in lumbar spine surgery that we still need to be aware about.
So what do you think the problem with clamping the TP is? What's the downside of that?
The downside, I think, is if you're at the wrong level, you've just potentially exposed the facet joint of that wrong level, or and created and honestly, some like a lumbar decompression, you're not getting out that far as well too. So,
right, yeah, that's what I was gonna say. Is that like my problem with that has always been, it just takes a hell of a lot. You can atraumatically expose the facet and still get out there, but it just takes a hell of a lot of work to do that. And I think, something under the lamina, it just lets you move the surgery along very, very early and just be confident in the level. I think the spinous process clamp is a loser. It is very confusing, but something under the lamina always points to that disc space, and it's just very clear in my experience. But
I've actually seen people get confused even with the under the lamina, Woodson under the lamina. Not so much when you're at L5S1 or L4-5, But certainly as you get higher up, sometimes there's enough shingling that you can be off quite a bit, right? The interlaminar window is well below the disc space, for example, as you get to like 2-3 or 3-4. So I clamp the spinous process, but I don't just clamp the process. I think, Anthony, you've seen this. I put a coker right at where I think the pedicle is.
Yeah.
So I am clamping the spinous process. I'm clamping the lamina essentially, but right where I think the pedicle of interest is. That's for like an open case. And we always count pedicles. We don't count disc spaces because I think disc spaces can get confusing, especially like at transitional level, right? Transitional levels run into trouble all the time. If you count pedicles, you're generally pretty safe. I think with the MIS cases, when you're working through a tube, you confirm where your tube is located. You're generally, or your guide wires, whatever it might be, you're generally going to be, a little more consistent because you're using more fluoro or more X-ray in the OR. So I'm glad you brought this up because this is not one that I would have thought of, but it's really important. I know I've had a case a couple of years ago where I started the case on the wrong side. We did a microdisc and it was meant to be a right-sided case, and I started on the left side. Now, in the end, it was a big enough disc that it didn't matter. I'm kind of glad I went on both sides. But at the same point, it wasn't obviously intentional. So, Matt, for us at Northwestern, partially because of me, I think, we are really particular about sidedness of the surgery to the point where we have to write down on the back where we mark the site. We write down right or left, and our timeout includes confirming the side of the pathology as well as the level.
Yeah, I love it. When I localize with fluoro before incision, I make a big arrow to the correct side and all the same things. Timeout, we say the sidedness and all that. So agree, that's very important. And I think is what I've experienced, like you're much more advanced than me, but I was super careful my first 2 or 3 years, and then I got to like year 5 and I started saying like, I can see what's S1 and L5 and I know where I am. And I started getting a little lackadaisical about it. And I think I've gone back. I didn't have any bad events, but I've gone back to being really, really vigorous with these kind of things. Because the more busy you get, the more you're at prey for something like this to happen.
Without a doubt. If you're not paying attention, this is one of those things, and we'll let you keep going, Anthony. If you're not actively thinking about it, you're going to get it wrong. And it's essentially one of the few things in spine surgery that's unforgivable. Like we can forgive durotomies, we can forgive infections, we can forgive neurological, I'm sure you're going to get to neurological complications. We can forgive the entire laundry list. Wrong level is sort of, there's no forgiveness there in terms of explaining it in a rational manner. And it's certainly one of the most common reasons for litigation. So I'm glad you brought it up. Let's keep going.
Yeah, obviously next to surgical site infection, that's a huge one. Either whether it be superficial, deep, most severe, most rare is post-op discitis or osteomyelitis. Different literature, reports have any surgical site infection rate anywhere from 2 to 4%, but obviously that depends now on the extent of the operation you're doing. Different operative approaches, minimally invasive has been shown to decrease some infection rates. And then you have a host of different risk factors that put patients more at risk that you need to be aware of before going into surgery, whether it be BMI greater than 30, diabetes, whether they've had a prior infection, what their nutritional status is. All of these that I've listed on there are, and I won't go in for sake of time, but are all big factors. And the main thing is, what can we do to prevent these surgical site infections? And I think going along every step of the way, there's something that you can do to better the odds and put you at a decreased risk. And I've seen massive surgeries that we do over here at Northwestern that, we were getting 1-level lamies over where I trained and getting florid infections and having the same rate of infection there that we even less over here at Northwestern with these big WACs. And how do they do it? Well, it's looking at all these factors, preoperative, really confronting your patients about smoking status, making sure that we do pre-op clinic visits, making sure their hemoglobin A1C is less than 7, MRSA screening, making sure we have chlorhexidine showers for several days in advance, and mupirocin nasal ointment for patients with positive MRSA screenings, preoperative antibiotics. within 30 minutes of the case. All of these are preventative measures that may seem routine, but some of these we tend to skip over, and they can put us at an increased risk. Intraoperatively, some centers have defined intraoperative protocols that they use. I'll just touch on some that we don't even realize is that our own sterility in there, whether it be double gloving and then removing the gloves after we've draped, has even been shown to decrease surgical site infections. I know vancomycin powder has time and time again been shown to have lower rates of infections. I don't know if anyone's had any experience with betadine irrigations. I'm not too sure about the literature with whether that really harms fusion rates in the end, but it also has been shown to decrease surgical site infections as well too. And then post-operatively, it doesn't just end with what you do in the OR, but post-operatively as well too, making sure that the incision remains sterile as possible. We usually keep the Aquacell silver impregnated dressings on there for several days, because these silver impregnated dressings have been shown to decrease surgical site infections. And then no real big benefit in keeping antibiotics going greater than 24 hours. Even with drain prophylaxis, we would keep it on for several days or while the drain was in, but that might just harm us more by selecting for more kind of gram-negative species. And I don't know if anyone has any experience with this, but more recently it's been applying superficial negative pressure wound vacs to these wounds. I know actually the ortho literature for joints and everything probably has more on that than the spine, but I've been reading a little bit more about this, and there's kind of conflicting reports whether this really does anything or not for the spine at all. So I think it's an interesting subject to look at down the road. Going further, things as simple as the positioning we need to watch out for. Keeping a patient prone for greater than 3 hours keeps you at increased risk of pressure ulcers if not properly padded. Having SCDs on at all times, making sure we prevent that DVT and PE rate, making sure the arms are not too far outstretched forward, prevent any peripheral neuropathies, shoulder dislocations. And then the major ones, quadriplegia and quadriplegia secondary to cervical stenosis. When you're doing a lumbar case, the rate of tandem stenosis is in the cervical and lumbar spine is around 15%. So you always need to have that in your mind when observing patients in clinic. And then, is there tandem stenosis in the cervical spine as well too? Because keeping patients in a more hyperextended angle during lumbar surgery for hours on end, there have been reports of patients waking up quadriplegic, most are upper extremity weakness following that. And then kind of a other one that we don't really see a lot, but definitely is a major risk too, is kind of orbital compartment syndrome. Keep these patients keeping their head down, causing acute, exacerbation of acute angle glaucoma, acute vision loss in some of these patients as well too. These are all things that should kind of be, some are less so than others in the back of your mind when positioning patients and making sure that, you do your surgery as concise and quickly as possible and safely as possible, knowing that positioning risks are always there. Epidural hematoma rates. It's funny, one study I read did MRIs post-op day one on almost like all these lumbar decompression cases, and they saw that the rate of epidural hematoma was very high. It was in the 80s percent-wise, but that rate dropped down to 36% of a subfascial drain was present. Now that's acute asymptomatic epidural hematomas. What about the symptomatic epidural hematomas that have to come back for surgical exploration? Well, in the end, they found that there was no real correlation between use of a subfascial drain or not. It is relatively rare to be reoperated on for a lumbar epidural hematoma. I think the rates that I saw were between 0.1 and 0.2%, but again, it's not zero. But it does show that, even though subfascial drains are useful for limiting subfascial blood and epidural hematoma rates, hasn't really necessarily correlated to a decrease in symptomatic epidural hematoma formation. What risk factors are there for epidural hematoma formation that could be symptomatic? Well, definitely the number of surgical levels you're doing. Increasing age has also been correlated. Can't really find strong evidence to correlate postoperative reinitiation of a patient's antiplatelet or prophylactic or therapeutic anticoagulation with the onset of symptomatic epidural hematomas. But strangely, one thing that I did find that was correlated, that several studies did correlate, was sharp systolic blood pressure increases at the end of your surgery. Like several groups, actually 2 groups in Japan, I think, looked at this, and they found that blood pressure spikes in the even 170s, 180s, 190s as patient is waking up from anesthesia. And this isn't just cervical and thoracic. This is also lumbar spine, that they showed an increase or in your epidural hematoma rate as well too. So that's something to think about. When incision's all closed up, the case is ended, and you're feeling pretty confident about it, is that we're not out of the window just yet. There's always potential risks for epidural hematoma with that.
So anesthesia can hurt us on the way in and on the way out.
Exactly. They can never stop hurting us, basically. So.
I was going to say, like, sharp systolic blood pressure elevation, I thought that's just like extubation. I mean, we just see it all the time, right?
Yeah. I mean, I always just correlated, like, it's funny because I always just did that for brain tumors and cranial surgeries, watch the systolic blood pressure when you're waking up, when in fact I should be also focused on some of these spine surgeries that we do as well too. And then something that we don't necessarily think about or put too big of an emphasis on postoperatively that actually can have a significant effect on a lot of our patients is postoperative urinary retention as well too. Rates can be as high as 20, almost 30% of patients in lumbar spine surgery that have a degree of urinary retention post-op. And obviously, you start to see these again in the elderly, in patients with history of BPH, and patients with history of post-op urinary retention, and also of higher opioid use. So, and again, what are they associated with? They're associated with increased rate of UTI, longer hospitalization rates, prolonged hospital stays. So it's something that, even though it seems small, we need to be on top of it to reduce future complications down the road. And really, it's how do we prevent this? It's from avoiding any anticholinergic medications, trying alpha blockers. And then also I've seen, actually, a lot of this isn't in the neurosurgery literature, it's in the nursing literature, where they have set postoperative protocols for voiding, some say immediate post-op discontinuation of the Foley and the PACU, set 4-hour PVRs, and encouragement to void no matter what. So it's actually in the nursing and in the anesthesia literature that I see a lot of this. And it's there's no easy answer for how we tackle this problem, but I think that vigilance is kind of one of the best things we can do. And also vigilance to realize that in the very, very small subsection of patients that have urinary retention, maybe it's not just urinary retention from anesthesia. You have to look at, do they have saddle anesthesia? Is this part of a bigger picture of post-op epidural hematoma or choroidal equina picture that you need to look at afterwards? So always just be vigilant afterwards about that. So then moving on for the sake of time, iatrogenic instability that we can cause. It's documented in biomechanical studies. Removal of a third to a half of the facet joint can significantly increase post-laminectomy stability. Fracture of that pars of the pars can not let you be able to resist translational forces, leading to spondylolisthesis. I've seen studies that say that even risk factors for post-op instability following laminectomy, probably more higher with patients with preoperative spondylolisthesis. Maybe it's not mobile and you do a laminectomy, just hoping to kind of get away without fusing those patients. Well, those patients still afterwards have an increased rate of iatrogenic instability compared to patients that do not. So, and I found interesting too that MIS decompression cohort may have less of a chance of postoperative instability compared to open. And is that because that we are kind of sparing those posterior tension band, sparing those posterior ligaments that could limit flexion, could come into play with giving us a little stability afterwards. So that's definitely something to keep note in your head.
And when we finish this talk, I want everyone to take a brief second and Google that last author's name. Matt, do you remember that story a couple of years back?
Remind me.
Neurosurgeon in Toronto. He's now in jail for killing his wife. It's a super sad story, but when I saw this paper pounce up, that's the first name I noticed. It's a terrible story, super terrible story, but it's worth a read nonetheless, because it's another spine surgeon going off the rails, you know?
Yikes.
Yikes. All right. Keep going, Anthony. Sorry to interrupt, but I just
No.
let the opportunity for gossip go away. I can't.
Yeah.
I have to gossip.
Could you just can you go to the next?
Oh yeah, my bad. Sorry. Yeah.
Okay. My computer's really slow. It's not going too quick. Yeah, neurologic injury. I think through the literature that I looked at, I think that a lot of neurologic injury in lumbar spine, I think, is definitely approach specific or more attributed to instrumentation cases. I mean, that's not to say that you don't get neurologic deficits with simple discectomies, simple lumbar decompressions, as I have more slides on that later. But a lot of meta-analysis that I've seen shows that this rate's usually 1% to 2%. A lot of it may be related to graft implantation, pedicle screw malposition. It's not often that we see neurologic compromise with simple decompressions or discectomies, but it is possible with retraction of the nerve root as well. And then pseudoarthrosis rate, you can get away with it. It can be symptomatic, but or asymptomatic, but in the absence of bony fusion, months to over a year down the line, patients that are still complaining of baseline pain, that should spur in your head a workup that there's, there may be a pseudoarthrosis. And you can make an argument, things like pseudoarthrosis, adjacent segment disease, are these true complications, or is it just the risk of your approach of, the surgery that you're doing? But nonetheless, I thought it was worthwhile to talk about, because you need to see who is at most risk with these types or of getting pseudoarthrosis. Again, it's the patients with higher BMIs, it's smoking greatly increased. That's why we, have a strict, we do nicotine tests on some of our patients preoperatively, just to confirm that they're done smoking, because it can hinder you that much. Chronic steroid use, diabetes, and then surgical planning and surgical technique as well too. I know with sagittal balance, if there's tremendous sagittal balance or presence of a segmental kyphosis post-op, that can just put a greater stress on your construct and lead to higher rates of pseudoarthrosis. So it's medical factors, it's surgical factors, it's a combination of multiple different things, multiple different sides that have to be in your mind when you're thinking about how to limit pseudoarthrosis rates.
Hey, Anthony, I know you put together an awesome talk, and we gave you one of the big topics, right?
It was
all the complications that can happen from the surgery we do. Give that to the fellow. That was our thought process.
Yeah, well,
we are at an hour, and I want to respect everyone's time. So, but thank you so much for putting that together.
It was my own fault too. I'm sorry for the technical difficulty.
No, don't worry about it. Don't worry about it. I think what I'll do is again, just thanks for putting that together. I think it was really helpful to hear and think through it. Mm-hmm. Some of the things we talked about, are honestly complications. Back when I was in training, we just sort of accepted them for where they were. And we never really thought too much about how do we prevent it. I mean, the number of infections I saw in training compared to now is substantially lower. The number of osteoporosis related complications substantially lower. I'm not sure if you went into this discussion or not, but on like PJK, we saw tons of PJK. And it's not that we're not done with junctional kyphosis, but I think we see a little less of it now than we used to because we're thinking ahead. And so that's probably the take home point to the, to the residents and for the fellows listening is to say, like, let's keep thinking ahead on the potential complications and really mitigate against it. I think is the real take home mechanism. I hate this concept of never events. You've probably heard of them, and CMS loves them and administrators love them. There's nothing that's a never event other than probably wrong site, wrong level surgery for us. But the other stuff is how do we get incrementally better? But let's spend a couple minutes before we sign off. Any questions from the group or thoughts or comments about what we've talked about?
Yeah, I guess I would say that going into, I was also going into detail too about specific specific complications with specific techniques, ALIF, XLIF, TLIF, and what I kind of just saw is that what do I do? Do I do an ALIF in this situation? Do I do a lateral in this situation? What's the best? And I think that it's your comfort also plays a role, and the learning curve that you have over time with this certainly plays a role too. So I think that especially during training, that's definitely an important part of my training was getting I've had complications, I've had things go wrong with all these different types of procedures, but I think it was that learning curve and being in the OR and getting those reps over and over again that have really taught me what complications to look out for and certain techniques on how to look out for them. So that's just kind of my message to the residents and everything too. So
Anthony, this was so comprehensive. To have a meaningful discussion about all those topics in under an hour is hard. So thank you. That was really well done.
thank you.
So Dr. Patel's computer just crashed. So Anthony, thanks for the talk, and Dr. Coleman, thanks for listening in. But that's why the screen share is no longer with us. But yeah, so I'll be up next talking about infections, I think in 2 weeks. So we'll continue the rest of this curriculum. I think we got another four talks after this one. But yeah, all right. Thanks everybody for tuning in.
Appreciate you guys having me. Thank you.
Yeah.
Do it again.